हेलो व्यूअर्स, आज हम कुछ आपसे दिल की बात करेंगे. Let's talk about heart disease in Indians, some things at the top of everyone's mind these days. Are Indians actually more prone to heart disease? What is the story about progression of heart disease in Indians? Is it more serious? Do we have a much higher array of risk factors? What is it that pushes Indians towards heart disease? And we're all reading news about young Indians getting affected by heart disease. To answer your questions today, I have with me leading experts of the country. I have Dr. Ashok Seth, who's a chairperson of the Fortis Escorts Heart Institute. I have Dr. Balbir Singh, who's a chairman of cardiac sciences at Max Healthcare. And I have Professor Karthikeyan from the All India Institute of Medical Sciences, Department of Cardiology. Now, we all know that, when we were young, then India was considered the land of communicable disease, that people died predominantly of communicable disease, infectious disease as it is. Over the years, the profile has changed, and more than 50% of deaths in India, probably more than 60%, are related to non-communicable or non-infectious diseases. Among these, heart disease is dominant, and it's said, based on some data actually, that maybe 25 to 30%, maybe even a little more, of deaths in India are actually occurring because of heart conditions. It's not just that. We seem to have younger people getting affected more and more. We also seem to have progression to hospitalization and serious conditions more in Indians. Let's look at each of these points today as well as we can, as clearly as we can, and try to simplify for you with the help of our invited experts so that we can understand more about our hearts and protect our hearts from any future damage. I'll start with you, Dr. Seth. There are many unique features of heart disease in Indians that are talked about. So, is the overall risk really higher in Indians? Or is it just one of those things that is talked about?
So let me just put it into a very important perspective. There's no question that the risk of coronary artery disease in Indians is high. In fact, it is clearly all across the world being documented. And when I say all across the world, I also mean in Indians living in the United States, and Indians living in UK, Indians living in Singapore, and Indians living in West Indies, that the risk of coronary artery disease is 2 to 3 times higher than the West. What is not clear is, and it can be 6 times higher than the Chinese and 20 times more than Japanese. We certainly are the heart attack capital of the world. That is also well recognized. Even in the West, there are more heart attacks occurring in the Indians than compared to the local population. What is not clear is whether this is related to just the higher incidence of risk factors, like the metabolic factors of diabetes, hypertension, and metabolic syndrome. Or is it truly genetic? Is not very well understood. There are in fact indicators when one would say that even corrected for the diabetes and hypertension in the population, in the population of United Kingdom, in the population of even Singapore, and even in the population of West Indies, who've been actually living for generations in that area, who've changed their lifestyle according to local, there is still an increased risk. So yes, we think that there is a genetic predisposition, but this other issue is there's no doubt that there's an increase in risk factors. And that increase in risk factors is not just metabolic, not just diabetes, hypertension,
something more.
But there is something more than that. Yes.
And it translates into more serious disease?
It does translate.
One is just minor heart attacks? Or,
yes, so. It translates, is that again is a difficult question to answer. Does it translate into more serious disease? But yes, there are a greater number of deaths. And while the deaths from heart attacks in India is increased by 2 to 3 times over the last 40 years, last 30 years, I would say.
1990 onwards.
That's right, 1990 onwards. It has actually decreased in the West. Now that could be due to multiple factors, including care, etc., including the type of disease. But given diabetes and hypertension, given the smoking and obesity, we have more diffuse disease. We actually have much more disabling disease, and certainly in regional areas, it's been well demonstrated, and in the South, that is fairly diffuse disease, and we see that from many parts of the country as well. So yes, we have I would say, put it as we have more serious disease, we have more extensive disease processes, and we certainly have smaller coronary arteries, and therefore we certainly need to take more precautions for this. So there is a whole variation for Indian coronary artery disease compared to the Western coronary artery disease.
So quite clearly, we are at greater risk of heart attacks. The incidence, prevalence of coronary artery disease in Indians is higher. There are multiple factors that Dr. Seth just discussed. But there are also other issues. And one issue, Dr. Balbir, that we are facing a lot these days is it seems that younger Indians are getting affected more and more. And you know, it's one thing, like in diabetes, we say that. One is the prevalence is increasing rapidly. Other is younger Indians are getting diabetes. The same thing we are seeing in heart attacks. While on the one hand, because of the excellent care that is available to some segments of the population, we see many people living to their 90s and late 80s after having procedures done, in their 60s or 70s, where probably earlier they would have not survived. On the other hand, we are also seeing people who we never saw, never suspected before, actually getting frank heart attacks or myocardial infarction. So what is this age story about India? And I link that to another one, the gender story, the men versus women difference, and how does it translate to India?
So thank you, Dr. Amrish, for this nice question. So in my family, I can answer this question because when I was a student, we were given a thesis to look at young MIs or young patients who get heart attacks. So when we were given the thesis that you look into patients less than the age of 40 years and come out with some answers that how common is it, what are the risk factors. So the person who got the thesis was crying because he said, I will not get these patients. At the end of 1 year, he got very few patients. And my daughter is pursuing the same career, and now she has plenty of patients whom she can enroll in her study. So this clearly tells us that in 20 years that has followed, the country has seen a big change. And this is a clear example. I don't need to quote any textbook. I don't need to quote any journals. So if you look at our data on SO, 1 in 6 patients comes with a heart problem has age less than 40 years. I recently treated a heart attack with a 28 years. His pumping had reduced. So it is becoming more and more common. And this is a combination of multiple risk factors that have happened. It's the socio-economic change that has happened in this country, which has brought high numbers of young patients into this problem. So it is not a problem which can be just rubbed off or ignored that it is not there. It is there. We have to face it, and we have to change the society so that this does not happen. It can be, it is possible. It is a preventable disease. So it is a preventable thing. So we must work hard on it.
Well, it makes it very hard because if our young population is also susceptible to serious disease, it makes it very hard for any screening program or any program that has to be implemented at the public health level. It becomes a big challenge. And I suppose there'll have to be more and more upstream programs which are looking at just primary prevention rather than, actually picking up disease in these, because it's not going to be easy in vast segments of our population to do that. What about gender? What's your feel about gender?
So the gender, women at young age are protected by their hormones, but this is also changing fast. So we have been taught in the past that women in the premenopausal age are generally protected from a heart attack. They still are protected, but the problem is that now women have started smoking. The incidence of smoking has gone up in women. And smoking has a direct link with a heart attack. And women who smokes loses that God-given protection. So God has done a beautiful job. So he says premenopausal women need to take care of their children. Probably that's the reason. It's a philosophy, but it is a reason. So he wants to protect them because he knows that they have to take care of the children. So premenopausal, they are protected from heart diseases. But if they start smoking, if they get into all those risk factors, they are
even diabetes sort of takes
so they are also getting prone. So they are losing that natural immunity that was given to God by changing the lifestyle.
Add on to what Balbir is saying or Dr. Balbir Singh said, is also the fact that yes, it's the commonest cause of death in women in India as well. That's again an important thing to realize. 6 times commoner than the breast cancer. The second aspect is that we in India are getting heart attacks 10 years earlier than the West. So yes, our younger people are getting more prone to heart attacks, and certainly 25% of our heart attacks are happening in age less than 40, which is practically unheard of in the West. So we are definitely becoming a very important, it's getting very important for our young people to understand, not to get scared, but to also understand that we are prone to have coronary artery disease with heart attacks, and that we've got to do everything to prevent heart attacks at a young age.
Even in the younger age.
That's right.
So, Dr. Karthikeyan, India is not one. There are many Indias within India. So, let's say one were to talk, are you aware of any major studies showing regional differences or rural versus urban differences? Because see, if it's all in the genes, it should perhaps in a very simplistic way be the same everywhere. But we know that for diabetes, when you move from a village to a small city, the risk doubles. You move from a small city to a metro, the risk doubles again. So there's a big difference. So do you see that kind of profiling in this scenario of heart attacks also?
So just to step back before answering that question. So I agree with what has been said about the importance of having heart disease. I mean, Indians having a high incidence of heart disease. But the issue is that the way we frame it, it becomes a little fatalistic. So being Indian seems to be a risk for having heart disease. But if you actually look at all the data that are there, it doesn't really add up that way. So the initial studies that said that Indians were at high risk were all on expat Indians who lived abroad. Generally it is known that expats are younger people, they are probably richer than their counterparts in their native countries. So they have a different profile as such. So these data, they are true data, but they are not comparable to the natives living in the country. Now, the same way that Dr. Balbir pointed out that we are having more people, younger people having a heart attack now than what it was, say, 20, 30 years ago. So that also points to the fact that it's more lifestyle than genetics. The other thing that you asked about the regional variations and rural versus urban differences, all these again point to the prevalence of risk factors rather than an inherent tendency. The strongest, in my view, the strongest point for the risk factors contributing to the risk of heart disease in Indians is there are some studies, international studies, which have looked at the attributable risk of all these risk factors contributing to the risk of an MI. And it has been found that about 90% of the risk of a heart attack can be explained by these conventional risk factors. And this is the same for whether you are an Indian or a Swedish or American or a British person. So there is a 10% risk which is not explained by conventional risk factors, but 90%, the vast majority. So this really, I'm making this point so that people understand that you don't have to be fatalistic about having a heart attack just because you're Indian, because most of the risk is controllable by controlling these risk factors.
So the important point you're making is that most of it, not all, but most of it can be probably managed by managing conventional risk factors, and we'll come to each one of them separately soon. And those risk factors per se have increased in Indians a lot.
Correct.
And those risk factors have probably increased because of lifestyle or environment, because the genes haven't changed.
Right.
So ultimately, as we move backwards from the end point, which is death or heart attack, we move backwards, we're looking at risk factors. And again, if we probably correct those risk factors in the beginning, or don't allow them to develop, then probably we can, stop sliding down this path. And I think that probably is the message that I'm getting. So the important point is, while Indians do seem to have a higher prevalence of heart disease, much higher prevalence of heart attacks than their Western or other populations in the world, but the fact is that still it is all possibly preventable. And at least the greater risk that's seen in Indians is possibly preventable. And we'll go into what are the risk factors we need to manage to be able to reduce our risk of heart disease and keep our heart safe. Let's move on. Dr. Seth, there's all this about, I see these patients, these young patients sometimes who go to gyms and take supplements that I don't understand, and they walk like that. And some of them, of course, we deal with the hormonal issues, and they have a lot of hormonal issues. After they stop their supplements, there's a big challenge in managing their lives. But I've also seen, and my cardiology colleagues tell me, that some of them, get unexpected heart disease and heart attacks, and they find very funny-looking hearts when they sort of try to intervene. So what is your feel about that?
Right. No. And yes, before I answer that, I'd also like to sort of augment what Dr. Karthikeyan said. Very important message his was that he said fatalistic. What he means is inevitable. I don't think everybody in India, just because an Indian should feel it's inevitable कि heart disease होनी ही है, तो हमारी तो किस्मत में लिखा है. Actually, that's right. Prevention and getting the risk factors together could change a lot of that. So I think that is a very important message to augment. It's not inevitable. It's just not. You can't. आपकी किस्मत में नहीं लिखा है. It's actually still in your hands to prevent heart disease. This important aspect you said about exercising. There's nothing wrong with. Firstly, of course, let's get this exercise issue again correct.
So we'll come back to the exercise in detail.
Okay, so you wanted to about the gyms? About the gyms?
The gym and the hormones.
Okay. See, gymming, there's nothing wrong with gymming.
Yes.
In fact, gradually, one should actually, gymming has all sorts of exercises, and it could be a combination of aerobic and anaerobic exercises. So we'll get to exercises later. But I think whatever artificial you take for increasing endurances, building up muscles, and actually getting your physique in order. And these are usually very damaging hormones and steroids, and even products. They could be very high increased level of proteins. All of those are known at unnatural levels to be able to damage both your heart, your muscles, your body, your kidneys. And I think there is nothing there which actually should make you actually take those. So very clearly the message is absolutely no. Every form of exercise is good provided you graduate to it, and both anaerobic and aerobic can actually help you, and gymming is not a bad thing at all, provided you stay away from.
It's the stuff
absolutely,
you take along with
you
that.
stay away from any artificial products which are supposed to build your body up or muscles up and so on and so forth. They are harmful.
So they're really harmful for hormones, as we see every day actually, and use of high doses of testosterone and others. And then when you stop those hormones, then all kinds of things happen. And the person actually, I've seen young people's lives go for a toss simply because they sort of indulged in all these activities. So we'll take a short break and be back with you soon.
नमस्कार, मैं और राजा रेड्डी और राधा रेड्डी हम दोनों आ रहे हैं संसद टीवी के द्वारा आपको कुचिपुड़ी का महत्व बताने के लिए। नाट्यम कुचिपुड़ी नाट्यम भिन्न रुचिर्जनस्य बहुधापि एकम समाराधनम। This Kuchipudi Natyam provides you unified forum and gives an universal enlightenment. वो है कुचिपुड़ी नाट्यम।
Dr. Karthikeyan, I'll come back to you again after this short break. And the issue about genetics, and we keep sort of struggling with it in the field of diabetes also, and are Indians genetically more prone? And there are a lot of things that seem to suggest that, but we haven't nailed anything yet. We haven't got a solid thing to say, yes, Indians are genetically more prone. You do these GWA studies and you find some little gene here or there, some polymorphism, but nothing that will tell you that this is the gene that's causing this problem. So what's the status in heart disease?
So specifically for the risk of heart attacks, like you said, there are many genetic studies that have been done all around the world, and they've identified a few loci in some genes. There's never really been a pathophysiologic understanding of how these things contribute to the heart attack in the first place. And also the contribution of each of these is very, very small. So even if you were to alter that genetic abnormality, it is unlikely that you'll make a big difference in the risk of having an MI. So if we have to think, now that we don't know, if we assume that we don't know anything about genetics, then we can assume that maybe there is a polygenic, multiple genes affecting the risk of having a heart attack. That is a possibility, but as of now, we don't know the identity of any of these genes or genetic abnormalities that increase.
But there has to be something genetic, right? Because Indians living in the West, living across the world, seem to have a greater risk of heart disease than native populations, most native populations.
So that's actually a fraught. I think it's a biased analysis because populations are completely different. So, for example, the classic example that's given for Indians being at high risk is our younger age of onset.
Yes.
So the younger age of onset is simply because of the structure of our population. We have far more younger people. And if you have to, it's just a mathematical thing. So you have more young people having heart attacks, you have fewer older people, you have fewer older people having heart attacks. So if you average it out, our mean age is about 5 to 7 years younger. Now, in support of that, I would also like to point out that it's not only heart attacks. We have breast cancers 10 years younger. We have lung cancers 10 years younger.
Diabetes.
So it's all down to population structure. So my point is that you cannot simply say that Indians are more prone just because we are having it at younger age. Heart attacks are dramatic events. So obviously it stays in our minds and it has influenced our thinking in this way. But I would stop short of saying that we are inherently at risk. All the risk that we see, at least most of the risk, 90% of the risk, is because we are a sedentary population. So an ICMR study recently found that 50% of us don't do any sort of physical activity. And if you were to look at the WHO recommended level of activity, very few of us do that level of activity. We have a diet which is high in carbohydrates. And that also.
So we'll come to all the risk factors.
Sure.
So you're again saying, but still I find it difficult to understand because when we see non-resident Indians in more sort of developed, affluent countries like UK or USA, we find that they're bigger, they have more protein, they are bigger, they're more athletic. But it seems that the risk for heart disease does not go away down the generation. So I guess that's an unanswered question, you see.
So if you really look at the data, just look at the data.
Yes.
So all of us cite the global burden of disease data for mortality due to CVD and everything else. So if you look at the incidence data, incidence for new onset heart disease. So most of them are myocardial infarctions. Correct. So if you look at incidence by an age standardized population, so you take take out the age population structure. It's in fact similar. So if you look at South Asia, it's about 132 per 100,000. This is 2017 data. And if you look at Western Europe, which is what we normally compare with, they are almost same. In fact, they're a little more. But the key difference is, like everybody else has pointed out, we tend to die more often because of this. So we tend to progress more, we tend to die more because we are not able to take care of our risk factors so well. It's not just our physical activity, diet and all those things, but it's also our access, affordability of medicines, things like that.
There's so many things, yes. As I said, there are many Indias within India.
Indians definitely die more often because of heart disease, far more often than Western Europe.
If you use death as a parameter, then you will find
most definitely. And that is probably the most important parameter. So it is a problem. It's not that, I'm not trying to downplay the problem. I'm only trying to say that let's not think that just because we are Indian, we have a higher risk of heart disease. So we can control most of it, and we should try and control most of it.
So, Dr. Balbir, I come to you with a very important question, something that is discussed all the time and is also controversial, as most things over here, is the story of lipids and heart disease. So, there are two sort of angles to it. One is, how important is the role of cholesterol in promoting progression or gravity of heart disease? Which cholesterol, the Indian type dyslipidemias, do triglycerides play any role? Should we be managing triglycerides? Should we be worrying? There are all kinds of myths among the public that say cholesterol actually doesn't matter and the whole thing is a stunt that is created by industry and doctors together. What is your feel about the cholesterol thing? And subsequently, in the next round, I'll ask you about statins, but let's talk about cholesterol first.
Okay. So cholesterol is the single driver of atherosclerosis. There is no doubt about it. There's no controversy, there's no discussion about it. We had the Birmingham Heart Study, which was done many, many years back, clearly establishing a role between cholesterol, heart attacks, and coronary disease. So there is no doubt left in anybody's mind that cholesterol is important. We go back to the Inter-Heart Study, which Professor Karthikeyan was mentioning, which has done from 52 countries. Two major risk factors were smoking and lipids. So lipids was again on the top. So smoking and lipids were two important factors. So now we come to which cholesterol is bad and which is good. So LDL cholesterol is clearly the driver of atherosclerosis and not triglycerides. Is an Indian dyslipidemia different from the Western lipidemia? Well, the only difference is that Indian LDL, for the same level of LDL, Indian has a higher tendency to develop atherosclerosis. These are some suggestions which suggest that the Indian coronary disease is far more aggressive than the Western atherosclerosis. We know that from our experience, and Dr. Ashok will bear me out, that when we look at the coronary angiograms of the Indian patients, we do much more difficult job than what they do for the same age of patient. For a similar age, diabetic or non-diabetic status, the kind of vessels they do look big, much simpler lesion. What we do is a diffuse disease and bad disease. So our experience bears out that we have more aggressive atherosclerosis in this country. For the same level of LDL cholesterol, we have more atherosclerosis. The second thing that has been borne out is by the Lipid Association of India, which has changed its guidelines and made less than 50 as a benchmark to prevent coronary disease, which is less than 70 in the Western study. So LDL cholesterol guidelines for India are different from the Western population, clearly different. It tells us for the same amount of LDL, our disease is much more aggressive. So whether it is genetic, whether it is combination of multiple risk factors is something which, and a good epidemiological study can solve. But it's not my job to do it, but I have to believe that Indians are prone, Indians get more aggressive disease. Harder you work on the statin, on this cholesterol, the better outcome is. So
they're important.
Very important.
So for all of you, LDL cholesterol is what we call the bad cholesterol. And the bad cholesterol, while the levels may not be that high, even moderate levels of bad cholesterol can possibly be more dangerous for Indians. So meaning that do not get swept away by propaganda that tells you that cholesterol is not important. The naughty hypothesis, I got a WhatsApp saying that. So that's really not, that's misleading you. People who are sending you those are not your friends. Do take care of your cholesterol. Do make sure that your LDL is under control depending on what your doctor advises. The targets and all can be discussed on an individual basis with your physician. The other thing is the good cholesterol. See, we also have a good cholesterol called the HDL cholesterol. The LDL is bad. The HDL is so-called good cholesterol. Well, we Indians seem to have a low HDL, like a low good cholesterol. And that's also supposed to be a reason why we get into this trap of coronary
So now
disease.
HDL in Indian patients is low. Now whether it is genetic, whether it is lack of physical exercise, we are not sure on that. But we can't do anything to increase the HDL except advising good exercise because there is no drug to improve the HDL levels as of now. All we can do in patients who have low HDL is to get their LDL further down so that we protect their heart disease. So the key message here is that LDL is the goal of treatment for whatever way you do. Forget about the HDL. If your HDL is low, start exercising, which in any case everybody has to do, and concentrate on LDL levels. Same is true for triglycerides. Unless they are above 500, we shouldn't try to treat them because they won't do much. You again treat the LDL rather than the triglycerides.
So important that a lot of you come to us with worried about your HDL. Well, you can help your HDL a little bit by regular exercise, but don't worry about it. Make sure that your LDL, the bad cholesterol, is down. So if the bad is down, the good will overpower it. So try and attack that. Don't worry too much about not being able to get your good cholesterol up because that can be very, very difficult to do. And there are no really good medications that do that, unlike medications for LDL, which will bring it down, the bad cholesterol. So, Dr. Seth, I'll come to you with another major area here, and that is hypertension. And hypertension, as you know, is even more common in India than diabetes. What's the role of hypertension as a risk factor in all this?
The role of hypertension is very important in multiple ways. But first thing very important to understand is the silent killer. Now 25%, maybe 25% of the Indian population does suffer from hypertension. I mean, when we do routine checkups, and this was one of the CSI studies where routine checkups was done across, on a World Heart Day across the nation, and more than 1.5 lakh people were examined routinely at bus stops, at railway stations, etc. 25% turned out to have. Well, that you may call that a casual reading. You may call that,
but
that
true that
it just puts things into perspective. That it does exist. It's a silent killer, and it's become a most important, should we say, our target for control if we got to control the health of this nation, because hypertension is not just a risk factor for coronary artery disease and an important risk factor. It is so for strokes, for renal dysfunction, for kidneys, in fact, for any form of peripheral vascular disease. So it's one of the most important killers. In fact, it is actually the one to be modified along with diabetes, the two important aspects to be modified in this country, right from the grassroots levels. So that's the first part. The second part is that hypertension can be controlled by natural methods also. And I think that's so important. So it's a lifestyle disorder also. While in younger individuals, it may have certain pathological basis. It can happen from kidney disorders. It can happen with other endocrine disorders. But we talk about those in a very young age. When we talk about the majority of the Indian population, around 40 and above, this is all hypertension which is lifestyle modulated. And for example, just even exercising daily and losing weight will drop the high blood pressure on average by 10 millimeters of mercury. Now 10 millimeters of mercury decreases the risk of heart attack immediately, dramatically. So I would say that hypertension needs, everybody in this country should at least measure their blood pressure regularly and occasionally. Now they can do it themselves, or they can just go to a general practitioner. But because it's a silent killer, it becomes a responsibility right down to the grassroots levels and the villages, even for our social health workers to be measuring blood pressure. And by the way, high blood pressure measurement and sugar measurement become a part of our community medicine itself. So yes, this is one of the important things to take care of, and I would urge everybody to be sure, at least understand what their blood pressure reading is. And if it is high, take every effort to control it, firstly by natural methods, if it's mildly raised, and we talk about mildly raised when it's over 150, over 90, but if it's anything beyond 160, you start needing to get to medical measures, and that means getting down to a doctor and making sure that you monitor your blood pressure to get it under control. Now, every time we talk about, and I must urge this again, we have these conversations around what we have to advise to the public versus an individual. Now, we don't want every public to actually be, but I would say every person in the public should know his blood pressure reading. At least beyond the age of 30, should know at least once what his blood pressure reading is, whether that's measured by himself, by an instrument, or by anybody else. And if it's nice, once a year he should measure his blood pressure, know his reading. Of course, if elevated, he would actually just measure it more. And when we talk about a checkup, actually a checkup should only be a checkup of risk factor profile, to tell you frankly.
Absolutely.
And nothing else is needed in a checkup. And that checkup can be done even by a healthcare worker, because all we need to know is, do you have sugar and do you have diabetes? Do you have hypertension? All we're talking about is silent killers. बाकी तो being overweight, smoking, etc. you know it yourself. वो तो दिखेगा सामने.
ये जो blood pressure, diabetes ये मालूम नहीं पड़ता.
ये तो मालूम नहीं पड़ती. And that's what we talk about.
करना बहुत ज़रूरी है.
बहुत ज़रूरी है. And इसको check करा लेना या खुद check कर लेना बहुत ज़रूरी है.
तो ये बहुत इंपॉर्टेंट पॉइंट्स बताया डॉक्टर सेठ ने. इसमें आप एक चीज़ ध्यान रखिएगा, हम लोग हाइपरटेंशन जो डॉक्टर्स बोलते हैं वो हाइपर स्ट्रेस या इंक्रीज स्ट्रेस को नहीं बोलते हैं. हाइपरटेंशन एक मेडिकल कंडीशन है. इंक्रीज्ड ब्लड प्रेशर को हाइपरटेंशन बोलते हैं. और जो हम लोग वैसे टेंस कोई हो जाए या परेशान हो जाए, दैट इज नॉट हाइपरटेंशन, दैट इज जस्ट इंक्रीज स्ट्रेस और एंजाइटी और व्हाटएवर. दिस इज नॉट नेसेसरली कोरिलेटेड, राइट? सो समटाइम्स इट इज कोरिलेटेड बट नॉट नेसेसरली. एंड बिफोर वी टेक अ ब्रेक, क्विकली आई विल टेल यू अबाउट द इंपॉर्टेंस ऑफ डायबिटीज. द diabetes plays a very important role in determining the higher incidence of cardiac disease in India, or the rapid progression of cardiac disease in India. We know that India has a very high prevalence of diabetes that has increased exponentially from 1990 onwards. In a city, in a metro like Delhi, at the age of 40, almost 20% people have diabetes already. At the age of 60, 35 to 40%. And you add a whole chunk of pre-diabetes with that. So actually at the age of 60, only 1/3 people have perfect glucose levels. And that's important to understand because these conditions, along with all that has been discussed, will aggravate your risk for heart disease. So there is a strong link between diabetes and heart disease also, between cholesterol and heart disease, between blood pressure and heart disease. We'll take another short break and be back to continue the discussion.
नवंबर को अंग्रेजों के विरुद्ध स्वाधीनता की अलग जगाने वाले भगवान बिरसा मुंडा की जयंती को जनजातीय गौरव दिवस मनाने की शुरुआत प्रधानमंत्री मोदी की पहल पर हो गई है।
प्रधानमंत्री जी को मैं बहुत बहुत धन्यवाद देती हूँ कि उनके बदौलत आज जनजातीय समाज का एक पूरे देश में जो जगह पहले ही मिलना चाहिए था वो आज जाकर के 70 साल के बाद मिला।
जनजातीय समाज के प्रत्येक व्यक्ति को काफी लंबे समय से एक सुप्त कराह थी कि हमें कोई समझता नहीं है।
कला और संस्कृति मूलतः जिस रूट से हमारे पास आ रही है वो जनजातीय समाज ही है।
बहुत गौरव की बात है पूरे देश के लिए कि हमारे देश के यशस्वी प्रधानमंत्री जी इस तरह के विषय को भी सामने लेके आ रहे हैं।
Welcome back after the break. When we left for the break, we were talking about the difference between hypertension defined medically and hypertension what some people think it is. So when we talk of stress, hyper stress, increased stress, and lack of sleep, very common things in urban modern life. Dr. Karthikeyan, do these things also play a role or it's just a myth? You know, people often ask me, is my stress causing me a thyroid problem? It doesn't actually. So do you think stress and lack of sleep play a role in this?
So stress, psychosocial stress has been shown very clearly to be related to the risk of heart attacks at least. So psychosocial stress is, so it can be because of several things. So for example, one common cause could be because of lack of money. You have, somebody has stress because they don't have money, they have to scrounge for everyday whatever for food, and so that's a cause of stress. People may not have jobs, that's a cause of stress. Bereavement is one aspect of stress. So these things were actually evaluated in that study that we've been talking about, the Interheart study. So that was one of the most important causes, one of the 9 risk factors that contributed to the risk of a heart attack. So psychosocial stress is often ignored cause of heart attacks.
But till the Interheart study, there wasn't hard evidence.
Correct.
To really, we always spoke about it, but till that study came out, it wasn't really proven clearly that psychosocial stress can aggravate so many vascular and metabolic conditions.
So there are good mechanistic reasons why stress can cause heart attacks. So one of the most important consequences of high stress is increased catecholamine levels. That is one of the hormones which we generally refer to as adrenaline and noradrenaline. So that can increase heart rate, it can increase blood pressure, and there are some. So if somebody has heart disease which is even minor, so-called minor, not obstructive in the heart, the vessel supplying the heart, the sudden rise in blood pressure and heart rate can cause what's called a rupture of that plaque, and then it can cause a heart attack. So these are things which, some mechanisms by which stress can cause heart attack. And chronic levels of stress cause abnormal metabolism in the body. So it can cause diabetes, it can cause poor blood sugars. So all these things can contribute overall to increase.
How about sleep? Lack of sleep?
So sleep is probably a consequence of increased stress, but even otherwise, the data on sleep alone in isolation are not very good in terms of their link to heart attacks or heart disease, but then sleep is often associated, lack of sleep is often associated with increased psychosocial stress. So it's very difficult to tease out the differences between the two, but then
all these add up. So it boils down to a healthy lifestyle, and we'll come to a little bit more about that, how it all adds up. It's not one single thing. Sometimes we think in oversimplistic terms. I've got my cholesterol okay, so I'll be okay. My sugar is controlled, so I'm going to be okay. But actually, it's more of a moderate, balanced approach to control all your risk factors that will help you sail through this condition. Dr. Balbir, coming to very practical tips that people ask. And I know it is mundane stuff for you, but what are the symptoms of a heart attack? And are there atypical symptoms? We often know the typical symptoms of a heart attack. You want to expound on that a little bit?
Yeah. So this is very important that a person should recognize his symptoms for heart attack early, because it is a golden hour we have. If the patient reaches the hospital early, we can intervene and save his heart from suffering any insults. So it's a great time a person has from the onset of symptoms and going to a physician for help. Now, however, the symptoms can be very atypical. So one thing one should keep in mind is whenever they get a symptom, they should look back. Do they have risk factors? Do they smoke? Do they have a family history of heart disease? Are they diabetic? Are they hypertensive? Are they obese? If they have some of these risk factors, think that you must go to the hospital immediately. So what are the symptoms they should look for? So it is not a classical chest pain which majority of the times happen. It can happen, but majority...
That's important. That very often the classical central chest pain, not left-sided, typically central chest pain may not happen.
So the symptoms mainly are feeling uneasy in the front of the chest, on both sides of the chest, going both to the arms, or feeling as if somebody has held your neck, as if you're wearing choked, a very tight tie you're wearing and it's choking your chest. Or in the jaw, they feel there is some pressure in the jaw. These are common things which really should be taken into consideration. And you must go to a doctor who can take an ECG and a blood test, which can diagnose a heart attack and save many lives. So many lives are lost because they reach the hospital late. So picking up these small symptoms, sweating, or in elderlies, it is just breathlessness. They don't feel sweating.
Very important in diabetics also.
Diabetics and elderlies do not get chest pain or heaviness. They feel breathless, or they are unable to lie down flat. So these are very common symptoms and which are many times ignored. And many of my pulmonologists get these patients and they were actually heart attacks, and many can delay it into treatment. And this is very common. So keep a suspicion of heart attack as your first thing. Other things, if you go to the hospital and find out it is not a heart attack, nothing is lost. But if you sit at home and it was a heart attack, everything is lost.
The risk is too high to sort of... a lot of people confuse it with acidity, as we call it in India. And you know, it was just nothing, just some burning acidity. I overate at night and I was uncomfortable. Clinically, for a patient or a person, how would they distinguish?
So I tell my gastro colleagues that acidity, first think of heart disease, then think of your gastro problem. So first send the patient to us, let us rule out a coronary disease, then you treat it. Because acidity is so common.
Yes.
And Indians put everything to their stomach.
Yes.
They put many of the symptoms which could be something else to the stomach. Like constipation is common, so they feel constipation ho gaya tha, aur thodi ghabrat ho gayi, kuch khas nahi tha. So it could be something dangerous. It may not be something dangerous, but only a physician has the right to decide that.
Especially in those who have risk factors, it's probably important that not to ignore warning signs which may not be so typical as we often think. Dr. Seth, we already talked about this. One line about, do women have different symptoms?
Just, before we move away from the risk factors, I think it's very important to emphasize to everyone that family history of heart disease or dying, somebody, father or mother, dying less than age 60 is a very important aspect. Kisi bhai, behan, father, mother ki young age pe agar bypass surgery ho, ya stents jale ho, blockages hai, very important history. And I emphasize that again and again, that it's a multiplication of risk factors. So if there's a family history, and then yesterday I had a 32-year-old gentleman who was smoking and said, I'm 32, I've done nothing wrong. And why do I have a 90% blockage? And I said, what was wrong with you? You were smoking and you had a family history. That makes you 9 times, not just 1 + 1 is 2. Right. It makes you 9 times more susceptible to having coronary artery disease. And had you had hypertension, you'd be 18 times more susceptible to having coronary artery disease. So we must remember to control of risk factors is meant because these are multiplying your chances of having heart disease rather than just adding the chances.
So the same thing that I was saying, that when you have multiple risk factors, it all doesn't add up, it multiplies. That's what Dr. Seth is saying. And it's much more than just 1 + 1 = 2. And also the fact that if we correct all these risk factors, we are protecting ourselves to a great degree from the ravages of heart disease. But we come back to the symptom person. Yes, sorry. Of course, Dr.
Okay, is that we talk about young people having heart attacks. So, in fact, the same study that we have been repeatedly referring to showed that 90% of the risk attributable to risk of MI was attributable to smoking in people who were younger, about less than 45.
Amazing.
So, which means that if you stop the smoking, you would take away 90% of all the heart attacks in young people.
In young people. So when the traditional other risk factors haven't come into play to that extent, then smoking plays an even more important role in very young
especially
people.
in the young people.
Very important information again. So please give up smoking. I'm sure you've been told this before, but I'm repeating it. सिगरेट पीने से आज तक किसी का फायदा नहीं हुआ, कोई लाभ नहीं है. छोड़ दीजिए, शरीर के हर भाग को नुकसान ही करेगी. अगर मुझे हो रहा है चेस्ट पे,
करेक्ट,
और मैं दूर हूँ, मैं इतनी जल्दी डॉक्टर बलबीर के पास नहीं जा सकता कि मैं जल्दी से अपना टेस्ट करा लूँ, और मुझे समझ नहीं आ रहा मैं क्या करूँ, तो फर्स्ट एड में क्या करूँ घर पे?
So first aid, one thing to understand is, and I would just dwell slightly on the indigestion aspect also, because indigestion is actually common, and I've had indigestion, and I can't keep thinking कि heart attack ही हो रहा है. But I would say कि अगर indigestion within half an hour with antacids ठीक नहीं हुआ, to really rush to the hospital because it's likely to be, heart attack does need to be ruled out. So I don't think the first moment I get an indigestion, I have a unusual indigestion which is not getting better means go there. वो gas नहीं है, वो राजमा नहीं है, वो राजमा नहीं है, that could be a heart attack. And you're right. The first thing, I think it's very important to understand the first thing. It's usually a very oppressive pain. It's like you've never experienced before. That's how a heart attack occurs. And the first thing you do is take aspirin. I mean, that is perhaps the single most important tablet that I would suggest. Beyond that, everything means time is of essence. Get to the hospital as fast as possible. You need to be at a hospital. It has to be confirmed that it's a heart attack. And then whatever treatment is available at the hospital for treatment of a heart attack is most important. Our concern always is that for every minute wasted in the first 1 hour of the heart attack, and by the way, 10% of the people would actually die in that first time of the heart attack. In fact, half the deaths of heart attack occur in that first hour. For us, that first hour is the golden hour. And that is why we say, you don't have to waste time. We just get to the nearest hospital for treatment. The best thing you can do is take an aspirin and get there.
So aspirin tablet, how many milligrams? 300 milligrams? 550 milligrams?
I would say it's a 325 milligram tablet. The Disprin tablet is the best tablet because you can chew it. It is dissolvable. It acts fastest. But if you have any aspirin at home, whichever aspirin you have, you take it. I would even suggest that most people who at least have risk factors, and risk factors are certainly one of the risk factors for coronary heart attacks occur in people, those who have risk factors usually, should actually keep a Disprin at home because it's the fastest acting dissolving medication.
Fantastic information, very important information for all of you. I will come to nearing the end of the program, and I would like to ask Dr. Balbir a little bit more about where we left off the lipids. I cut him off at that point. Should we be taking statins if advised by the doctor, if we are at high risk, or are statins bad as is made out to be in so many media reports? Do they directly correlate with LDL cholesterol, or they are independent of that? What is the story of these drugs called statins that so many of you keep asking us about? I'm not going to take statins. Statins are very bad. They are bad drugs. Please, Dr. Balbir, can you explain that?
So statins are, in my opinion, a great drug. And I think if we go back in the last 5 decades, this is the greatest discovery that has been done. In fact, people who looked at the LDL receptors and statins were given a Nobel Prize. If we look at our medical literature, there's not one, there are lakhs of study, and every study with statin is positive. So there has been no question about the benefit of statin. It has been only questions in the WhatsApp messages. And I feel very sorry to see those bad messages on WhatsApp talking against statins, because statin at the moment is a wonder drug until it is replaced by some other drug. There has been some confusion whether these effects of statins are just by LDL lowering or they have something other than LDL lowering, which could be an anti-inflammatory effect. But by and large, most of us now understand that it is the LDL lowering effect which is the most prominent, because there are certain other drugs which lower LDL, do not have any anti-inflammatory properties, also benefit. So we understand that statins are very good drugs if used properly, appropriately, under the physician supervision. They can change the course of disease. They can prevent a heart attack. They can prevent a heart attack in people who have not had. They can prevent heart attacks in people who have had stents or have blockages in the artery. They can regress atherosclerosis. So they do all good things. So they are, in my opinion, being underutilized and abused by the WhatsApp group, and that should be stopped. You know, that's really dangerous.
So in the UK, the incidence of myocardial infarctions went up because people discontinued statins, believing false media reports. So we're running out of time, but I want Dr. Karthikeyan to comment about dietary measures. We've covered cholesterol, we've covered hypertension, we've covered obesity, we've covered to a large extent diabetes. What about dietary measures? Dr. Seth about exercise, and then we'll call it off.
The toughest for the end. So diet is a very, very difficult topic to discuss because it probably requires another 1 hour of discussion. But broadly, there are some things which are bad. So we can say, let's say trans fatty acids are really bad. So you have to eliminate trans fatty acids. So common food items which contain trans fatty acids are baked goods which are sold, so cookies and things like that, which
all
are sold
processed
elsewhere.
food which is stored,
Processed
and
food and repeatedly
all
fried
the cookies,
food.
everything that we have,
repeatedly fried
and
foods.
repeated.
So trans fats are
heating and
bad.
oiling.
So that is really, really very clear. The rest of it is not entirely so clear. So saturated fats, when you reduce saturated fats, they are known to reduce LDL cholesterol, but then it depends on, supposing we have to look at it in practical terms. So you reduce saturated fat from your diet, what do you replace it with? So that is the critical element. So you replace it with carbohydrates, then that's
That's
not
a
going to
mistake
end
that
well.
was made in world history of food, in the last few decades, that the Americans replaced saturated fat with carbohydrate, and we got more diabetes, more obesity. So you have to replace saturated fat with good fats.
Good fats.
From
So
nuts, for example. That's
So that is the difficulty. So people have earlier on people used to have an upper limit of fat in your dietary in overall in your diet, but then now that is being slowly relaxed. So it is not, fats are still not considered completely bad as they were considered earlier on.
But trans fats are bad. Reheating oil is bad.
Yeah, so that's
processed food which is bound together by fat with all kinds of fat dripping from it is not okay. But overall, fat has got some kind of reprieve, and at least good fat is now considered not unsafe for you, probably even beneficial because of other reasons. We're not going into it today.
Our diet in general is cereal based, and so we have a high carbohydrate content in diet. So that is one of the things that probably needs to come down. So maybe that in the long run will reduce our incidence of diabetes, and it has also got links with serum triglycerides and low HDL levels and things like that, which can ultimately impact coronary artery disease risk.
So quick comment from Dr. Balbir.
In 30 seconds, I would go back again to my college days. So we had a thesis which was published in British Medical Journal. So what we did is we looked at more than 1,000 people who were working in hotels and had access to the food which was free to them, and they could eat as much as they wanted. And at that time, there were no fast food restaurants. I know that very well. And it was compared against people with the same socioeconomic status. So people who had access to the hotel food, so high caloric food, they had 3 times higher chance of getting diabetic for the same age, same age. And this was published in one of the leading journals, British Medical Journal, clearly pointing out that high caloric intake diet is harmful.
Fantastic. The last comments about exercise.
Dr. Mittal, there's been a lot of interest on exercise in the recent times. And it's obviously, due to the events which have happened recently. I think I'm going to be very practical and put it into 3 buckets, because nobody needs to be scared about exercising. In fact, we would encourage the whole nation to exercise. It is the single most important method to decrease the incidence of heart attack, which is in everyone's hands, without doing anything extra. So that's very important to understand. And the recommendation for heart health is very clear. that we have to at least 150 hours, but I would even say go up to 200 hours, which means 40 minutes, 5 times a day.
So 150 minutes.
150 minutes per week.
Yes.
Which is 150 minutes per week, which actually means 40 minutes.
Maybe
40 minutes, 40 minutes, 5 times a week at least, of aerobic exercises, which to us is brisk walking, cycling, light jogging, are all good. Or you can have a combination of aerobic and aerobic exercises. You can actually also do mild weight lifting, etc. And then, of course, you don't need to do your 200 minutes a week. You can actually accommodate that in 100 minutes a week. But that is the heart-healthy exercise. This decreases the incidence of heart attacks clearly by 15 to 20%, improves on your weight, controls diabetes, controls hypertension, does all the right things, and gets rid of most of the risk factors for heart attacks. That is the reason why it's so important. The important aspect is what about, people ask me, what about if I do 50 minutes? What about if I do 1 hour? Can I do 2 hours of exercise? Yes, you can absolutely build yourself up to 2 hours of exercise, but what that does is improves your stamina, maybe weight loss. If your aim is to lose weight, it actually would make you spend more calories. It'll improve your stamina, it'll improve your well-being. Is bodybuilding bad? No, it isn't. Is extreme running or 10 kilometers running or 15 or 20 kilometers running bad? No, it isn't. If you gradually build up yourself to that level over a period of time that you can actually do it, all are safe provided you build up over a period of time. That's the whole bottom line to it. What is going to be bad is the third, unaccustomed level of severe exercise suddenly that you undertake without having built yourself up to that stamina or level, or your heart having built up to the stamina level. So what you see, and what we see sometimes, and certain collapses which happen, by the way, all the collapses and the things you see of somebody dying on a field or a football field, all those visuals are probably related to congenital heart abnormalities which existed, which weren't diagnosed in those patients. So don't think that everybody is dropping because of a heart attack all around. And the second aspect is clearly that unaccustomed level of exercise in someone who's probably had hidden or occult coronary artery disease and goes through severe exertion of some sort, which he's not been accustomed to, can precipitate a heart attack. But those are unusual and rare cases, and that is why we should not just as a public start believing that we're all at a risk and ready to die the moment we exercise. In fact, we believe that the whole nation should be exercising, and it's in your hands to decrease the heart attack in this country.
Thank you, Dr. Seth. Thank you, Dr. Balbir Singh. Thank you, Dr. Karthikeyan, for an absolutely wonderful, lucid, freestyle discussion on various aspects of heart disease, how to save ourselves, save our heart. और आपसे दिल की बात करके बहुत अच्छा लगा. I am sure हमारे दर्शकों को बहुत अच्छा लगा होगा. धन्यवाद. Thank you.